So welcome back. I hope you're nourished. I got a lot of numbers that I'm going to go through. So in this part of the symposium, similar to the sort of level setting that we asked Deb to do around the Medicaid program, we wanted to share some analytic work that we've done and that we've researched off of other publicly available data sites to get a sense of the kinds of services and conditions and treatment patterns that we see in the Medicaid population, some with some comparisons to historical fee-for-service Medicaid, some in comparisons to Medicare, some in comparisons to commercial populations, et cetera. So there's a lot of information in these 26 or so slides. So I welcome the opportunity to answer those questions as we go along, but I will also try to keep us moving because I think based on a couple of dry runs that we did with various folks, some of them data geeks, some of them not, we could be here for a while. So try not to do that. So first of all, let me just give you a sense of what we looked at for data sources. Most of what we looked at is publicly available, which is my way of saying that if you don't get what you want from me, you can go get it yourself, maybe. Sometimes with my help. So the Medicaid Quality Information System, MQIS, is a tool that I know many of you have heard of. Dr. Lotz in the back was instrumental in the vision for that. Our team helped on the technical side. It's really tied to reporting that is required of the managed care organization, so I'll be showing a lot of data as we go through of metrics that the MCOs themselves have reported to the system, and what I've tried to do within this with some help, exceptional help from the team, is try to pull multiple pieces together into one place. There are somewhere in the vicinity of 400 or so measures on the MQIS site, so you can be there a while, again, if you're not careful. And so I'd get some coffee, spend some time there. There's a lot there to learn, so we'll try to do a little bit of that. The Accountable Care Learning Network reporting site is a claims-based analytic tool that the Center for Health Analytics in IHPP has pulled together. There are analytic reports based on Medicare, Medicaid, and commercial. So there's a lot in this slide deck that's claims-based, so we'll walk through that a little bit. And then both the managed care organizations themselves and the External Quality Review Organization, the EQRO, on contract with DHHS, have reports that they put out on an annual or even more often than that basis. That's a wealth of information about the program. So there are some metrics that are pulled from that as well. And then there are a couple of key issues that we dig into just briefly at the end. And within that, there are some reporting tools that the Division of Public Health Services actually run that we tried to pull some data from as well. So just a note about those things. And we've tried to give you all of the links that you have that we used on the slides themselves. So I wanted to start with self-reported health. So the Consumer Assessment of Healthcare Providers and Systems, CAHPS survey, is a national tool that Medicaid requires the MCOs to survey the populations that they serve. And there are questions that ask the beneficiaries who are surveyed to rate their own health. And what you're seeing is the percent of survey respondents who rated their health very good or excellent. And I think the really interesting part of this is the difference between how the folks who are kids, which are the majority of Medicaid recipients, as we learned from Deb, the parent or the guardian or the adult answering on behalf of the kids are rating the kids' health pretty well. So 81% have very good or excellent physical health, 71% have very good or excellent mental health, but the adults on Medicaid, it's a different scenario. So the adults on Medicaid, as we learned again from Deb, it's a unique set of adults, many of them with some underlying health issues that are pretty significant that allow them to qualify for Medicaid. And therefore, we see that in the self-reported health as well. The 26% have rated their health very good or excellent. On the mental health side, that's about 30%. So again, just wanted to show a little bit of the difference that we see when we talk about the adult and the kid populations being very different in who Medicaid is covering. That being said, if you look at a number of different ratings that the survey respondents are asked to do in CAHPS that ask them about their own satisfaction with their care, satisfaction is pretty high. The rating of their health care, so in this scale, a 0 is bad, a 10 is good. The majority of recipients who are beneficiaries who are surveyed on both the adult side and the child caps are rating their health care pretty well, indicating that they're able to get the care that they need, rating their doctors well. This abbreviated thing that probably doesn't make as much sense to you is discuss what is best for them when discussing medications. That's the medicine one. Doctors showed respect. Doctors spent enough time with them and rated their ease in getting care, tests, and treatment. So across the board, according to the CAPS survey results, the Medicaid population, both on the adult side and the child side, are rating their ability to get care and their satisfaction with their care when they get it pretty well. So I'm going to spend a little bit of time digging into some of the claims analysis that we have, and there are some important caveats that I wanted to address before we do that, so bear with me here. For the data geeks in the room, this is all important. For the rest of you, it's important, but you might not think so. So the claims analysis is reflective of medical costs only, so this is not inclusive of the pharmacy experience. The pharmacy is something that we talk a little bit later at the end separately, so just keep that in mind. We know that pharmacy is a huge spend, so when you add those numbers in, these things might change a bit, but this is medical costs only. We use a 9-month continuous eligibility criteria, except for those under age 1, which means that we are trying to understand sort of what happens for folks who are continually associated with care, except if you were just born, you don't have to have been there for 9 months. Makes sense? Run-out period is 6 months. For the commercial and the Medicaid populations, all of the analyses are limited to those under 65. That's partly because we know that Medicare pays for part of that experience, and we don't have that wrapped in, so we don't want to confuse things. And they might, individuals who are over 65 might look like they don't have much spend, but that's because their spend in commercial is very small, but in Medicare is very high, and we don't have them all together. I see people nodding, so I'm happy there are other data geeks in the room. Thank you for being here. On the Medicare side, this is Part A and B only, and it does not include the dual eligible population. So again, when you have multiple payers, it gets a little weird, so we didn't have the dual eligibles in there. Couple of software notes. We are using the Optum Episode Treatment Grouper software, ETGs. ETGs are built on claims, as one would expect, and there are hierarchies of disease. So, for example, if you have both hypertension and congestive heart failure, you will end up in the congestive heart failure population. You will not also end up in the hypertension population. That being said, if you have a broken leg and hypertension, you will end up in both places. So there are hierarchies of related diseases, but if things are not related, you will get counted in both buckets that you find yourself in. ETGs roll into major practice categories, and we'll look at analyses on both of those levels, so high-level major practice categories and then lower-level, more detailed episode treatment groupers. There are also risk calculations that come out of this software that I will share with you. One risk is retrospective risk. That risk looks at a utilization history and ranks the risk of the population. The other risk looks at the demographics, age and gender, and gives a risk associated with the demographic profile of the population, and we will look at both of those. For anybody who wants all of the data detail, there is a user's guide associated with these reports, and the link is there. Okay, so what do we see? A couple of really important points to talk about the populations that we're talking about when we look at these data. The Medicaid managed care MCO data that I will show, time period was fiscal year 15, so running July to June, July 14 to June of 15. About 120,000 members are represented in that analysis. Again, that's less than the total MCO population, but we have those criteria for non-under 65. We have the criteria for continuous eligibility and those sorts of things, so those numbers decrease. On the commercial side, same time period, about 620,000 lives represented, so a much bigger population. That becomes important later. Just keep that in mind. I will remind you of that, but keep that in mind. And then we have a couple of reports or analyses that we tried to include that looked at a historical year of fee-for-service Medicaid before the conversion to managed care as a comparator. That was about 91,000 lives and was a fiscal year 12 experience, so it was a good long time ago and was certainly before managed care started. And on the Medicare side, same time period as the MCO data and the commercial data, about 200,000 covered lives associated with that. As Deb mentioned, Medicaid, largely kids. So we wanted to just show as a comparison in the populations, the percentage of the members in those populations that were under 18. 70%, 80% in the Medicaid side, much smaller in the commercial side, 22%, and almost negligible in the Medicare side, not surprising. But again, they are different populations. So we're going to talk about what we see in the data, which is really important, but we have to sort of remember that the populations that are underlying the data are very different from one another. Okay, so what do we see? These are the claims-based per member per month amounts on the medical side, so inclusive of all costs on the medical side. What's the per member per month cost? On the commercial, it's about $343. On Medicaid MCO data, it's $222. And on the Medicare side, it's $685. So keep in mind, utilization has an impact on per member per month. So if there's no utilization, it's not very high PMPM. Rates that people are paid are also important in calculating PMPM. So what you're going to see here is a combination of rates and utilization that drive that claims-based per member per month amount. From a risk perspective, the commercial population overall is a relatively, compared to the other populations, low risk on both the retrospective look and the demographic look, in that they're under 1. On the Medicaid side, the risk is about 1, and these are really just sort of relative terms to one another. And the Medicare is 2. So it's a high-risk population on the Medicare side from the utilization history. On the demographic risk, similarly, the Medicare population is a older adult population. They tend to be higher risk. Medicaid, interesting thing, again, because it's driven a lot by kids, the demographic risk is really a smaller number than you would see in some of the other populations. And on the commercial side, the retrospective risk and the demographic risk are about the same. So just some relative information around those populations. All right. So that's some overview of the claims experience. We're going to talk now more about those major practice categories and episodes that we see in these populations. There's a lot of numbers here. And like I said, we could do this for a while. So as I said, major practice categories are driven by these episodes. So if you have one episode, you're counted once. So this is the percentage of the population in each of these coverage types that had at least one episode that groups into one of these major practice categories. Again, important to remember that these, what people receive for care and what you see in the episodes in the major practice categories are driven as much by their clinical needs as by benefit design, right? So if you have a benefit design that doesn't include behavioral health, you're probably not going to see a lot of behavioral health episodes. If you have a rich benefit in one area or another, you're going to see episodes that are you have more likelihood of seeing episodes in those areas. But essentially across the board for all three kinds of carriers, quickly, this is what we've presented here are commercial population, the managed care population, and then that historical fee-for-service Medicaid population pre-managed care. And importantly, I think, the upshot of this is preventive care services, routine exams. That's the most common type of practice category that you see in all three populations. You see a pretty big shift when you look at Medicaid to commercial in the next most common one because Medicaid is lots of kids. So otolaryngology, ear, nose, throat, lots of ear infections. And you'll see that in the episodes when you get to more detail, but there's a lot of tonsillitis, a lot of ear infections in the Medicaid population by volume of members seeking those services. And interestingly, and probably not surprising to anybody, on the commercial side, it's really orthopedics. You got a lot of knees, you got a lot of back stuff that happens that roll into those categories on the commercial side. So this is the top 10 list for all three areas. Again, you can be in more than one. People are in more than one of these episodes that roll into practice categories. So this does not sum to 100 purposely. It is the percentage of the population that have one of these. It is not out of a total of 100%. Okay. Any questions about that before I jump into the next slide? Okay. So I debated a lot about whether to include this slide because it's really, in some ways it's a little misleading, not intentionally. And I think if I say it out loud, then it's never misleading, right? Like if I warn you I'm trying to mislead you, it's not misleading. But what we wanted to show here is how much money is being spent in each of these major practice categories. The comparison of one population to another is unfair here because the population sizes are so different. That's the sort of misleading part, right? So on the commercial side, you're talking about 600,000 people with a $453 million spent in orthopedics. The orthopedics in the MCOs is only 26 million, but it's also only 100,000 people compared to the 600,000 in commercial. So that's the piece to just be cautious about. But there was some interest in the work that we were doing and that we wanted to share around what is the total amount of money being spent in these big categories by these populations on a claims basis. And again, not surprising, on the commercial side, you see, again, a lot of orthopedics and then a good amount of chronic disease care in gastroenterology and cardiology is the next two. None of you will likely be surprised that psychiatry comes up number one on the Medicaid side differently than it does on the commercial side. And again, that's reflective of a combination of the needs of the population as well as the richness of the benefit, really, on the behavioral health side in Medicaid. Okay. Any questions about that? Okay. Hi.
Hi. Total costs.
Yes.
You don't really mean costs. You mean costs to Medicaid, what they reimburse.
Yes. Total allowed amount.
Big difference between that word and cost.
Yes.
Okay.
Cost to be reimbursed. The cost that was reimbursed. Yes.
Cost to Medicaid that was reimbursed.
Right.
Yeah.
That was reimbursed. Yeah. Right. So the allowed amount.
There's not data out there about what the true cost, the real cost is.
Well, I mean, I think to the effect, or to the extent that the charges that are reflected on the bill are real, you could look at that, but I think people would debate as greatly whether or not those charge numbers are reflective. So, yeah, I mean, I think we're talking about sort of the healthcare black box that drives a lot of the uncertainty in the conversation. But yeah, no, it's a good point. So yes, this is the allowed amount. Yeah?
Definition of psychiatry, does that include all behavioral health? Not just a meeting with a psychiatrist? It's everything, all behavioral health providers?
Yes. Yep. Yeah. And you can, we'll look at a couple of the more specific episodes that roll into that major practice category. I will note that chemical dependence is by itself, so it is separate in this. Okay, so looking as promised at the episode treatment groupers. So this is the more granular look at the conditions and the visits that are included in those major practice categories. Again, not surprising in all of the populations. That routine exam is the most common kind of visit that folks have. In the commercial population, again, a lot that's primary care driven, tonsillitis, immunizations, hypertension being the fourth one, so you are starting to see some of that common chronic condition in the commercial population. And in the Medicaid managed care populations, again, by volume, by percent of members with one of these experiences, it's driven a lot by what the kids get and what the kids see. As promised earlier, the tonsillitis and the otitis media, the ear infections, are high up on that list, with routine exams and routine inoculations being high as well. And not that dissimilar in the fee-for-service historical look. Again, both populations driven largely by kids, so by volume, by number of members, you see a lot of that routine care and primary care. However, when you talk about where the spend is, and again, I just feel like it's important to caveat that this is a mix of the need of the population and the benefit design that's going to drive what people actually get care for. But that being said, from a dollar allowed amount proxy cost, not really proxy cost, kind of thing. For what we have for information about what gets paid out, you see in the managed care population, depression being the most costly of the episodes, the most money being spent in depression, followed by neuropsychological disorders, followed by psychotic disorders. So while by volume, a whole lot of the kids, by dollars, a lot of the behavioral health issues. A lot of money in the commercial population being spent on depression as well from a rank order perspective, lower than a number of other conditions, but certainly important across the board. On the fee-for-service side, again, just a note about who moved into managed care and who was in managed care in that fiscal 15 year, which is that some of the optional populations would have been those that were going to get paid for intellectual disability services that would have not been in the managed care organization in that year. So that is number one in the fee-for-service side that didn't carry into the population on the managed care side in that year. Pause, digest. Yeah.
So is a big difference between the fee-for-service Medicaid and Medicaid managed care the carving out of the behavioral health component? So you see intellectual disability, depression doesn't show up in Medicaid managed care. We know those underlying conditions exist. They're still being paid for.
Well, depression is.
Right.
Yeah.
But
yeah, on those sort of specialty intellectual disability ones that were those optional populations that were not in managed care that year.
So
Yeah.
the services are still being provided. They're just being provided outside of
Right.
Medicaid managed care.
Exactly. Yeah, and a lot of that is that fee-for-service wraparound that Deb talked about. It's those populations that were not mandatory into managed care that traditional Medicaid continued to pay for. Yeah.
And then the commercial dollar numbers, those relate to what the commercial payers are paying and not co-pays or what the employer is
It's the
paying?
total allowed amount, so it would be the individual person's copay as well.
Oh,
Yeah.
fun.
You're welcome. I like to give people just a minute. I know it's a lot of information in the slides, which is one of the reasons we wanted to make sure that you got the slides. And called out that you can go do this all on your own. Do whatever you want with it. It's all online. My team likes to joke around, and I like to joke around with my team about how much fun I have sorting the data. There's like 6 columns, and you can sort it by any of the columns, and so I look at it rank ordered in a number of different ways. And I'll spend a lot of time doing that if you let me, which is pretty funny. The thing that I did want to mention is that these numbers, I'm going to show a slide in a minute that is a little bit different. So these are the costs associated with that condition. So if for all of the folks who had a depression ETG, these are the depression-related costs. I'm going to show you a slide in a second that shows you something slightly different, but I wanted to mention that. Okay. Any other questions about the data that I showed? Yeah, Ed.
At some point, it'd be interesting to look at comorbid conditions of those who have a medical condition plus or minus a behavioral health condition, whether it was addressed or not.
Yeah.
Because the data suggests that it drives the cost up when you do not increase it.
Absolutely, and there is a report in the reports. This feels so self-serving. That's really not the idea. But if you do go out to the reporting site, there is a report that does look at some of those comorbidities. So there's depression with or without a comorbid condition. There's anxiety with or without a comorbid condition, and there's a select set of comorbid conditions. But there's some indication of or some quantifying of the impact of having multiple conditions at the same time. Yeah.
Just to clarify, you said these are the costs associated with the condition, but these are excluding pharmacy?
Excluding pharmacy, yeah. So pharmacy added on would be substantial. We're working on that, just haven't gotten there yet. Yeah?
So does this say on the cost side, the commercial insurance in its top 10 does not have substance use dependence as one of its top 10?
And again, that could be as much benefit design as it could be need of the population. So if you have a lot of commercial plan coverage with a carve out around that, it could be, or a low level benefit or something like that. The richness of the benefit is going to drive what people get care for too. Yeah.
Just a clarifying question.
Sure.
Does New Hampshire have Medicaid as supplemental insurance for youth behavioral health benefits?
I'm not sure how you would describe that. I'm looking at you.
I know, and I'm looking back at you.
I'm with.
Yeah, we're together.
So I'm from the land to the south of
Yeah,
Massachusetts.
you might come up.
And we have a youth behavioral health system wherein individuals who are commercially insured who have a youth who meets medical necessity criteria for Medicaid covered behavioral health services
Yeah.
is covered under Medicaid as a third party liability.
Well, we definitely have,
So you
we definitely do have third party, like, yeah,
supplemental, so Medicaid is supplemental.
Yes,
So,
absolutely.
so that was one of my questions, where you
It's
have.
eligible,
Yeah, so we have a significant cost burden associated with
Right.
commercially insured individuals whose youth are receiving Medicaid behavioral health services, including acute care. So the breakout of that youth
Yeah.
subsegment
Would be huge.
would
Yeah.
be very important to look at in terms of understanding.
Yeah, and we actually are working on building some more of age as a layer of analytic across all of the reports. So I think your point's a really good one for that. Yeah.
These were all time periods where substance use disorder services weren't really part of the benefit package across the board. So were these categories driven by services or by diagnoses on the claims?
This is ranked by the dollar.
But how did they get into those different categories? Was it based off of the service type or the diagnosis?
Service. It's a combination of things, actually. So the episode could be defined by, it's typically defined by a combination of both diagnosis and service type. Largely diagnosis based, but there are some service type pieces in there as well. Yeah.
Are there any states that are further down the road on integration of behavioral health and clinical medicine that we could maybe make some predictions on if we do a good job with that in the next few years, that we could see our Medicaid spend in the behavioral health category move in a direction?
Yeah, probably. I think we'll hear a little bit more about some of the models in some of our neighboring states and how far they've come. Some of those states have these kinds of claims databases that would allow us to do this sort of overall look.
But I guess my question is let's say we do a really good job, are we gonna see these numbers move at all, or is it gonna be the same, just maybe better care?
Yeah, I mean, I don't know. I wish I did. I wish I had that magic ball. I think one would hope that I think if we look back at the science of the amount of unnecessary care that's been estimated, you would assume that with better integration, some of that unnecessary care would be addressed and the numbers would go down. I think it's one of those, I used to do disease management work, and we always ran into this with our clients that wanted big results in depression, and we had to sort of remind them that actually if you better manage depression in the early phases, you're probably going to see increased numbers of care, increased care numbers and increased dollars. So I think the point at which that the time period that we look in when we say how much of it is we're catching up to improving the kinds of care that people should be getting that they haven't been getting, and when does that plateau and we could actually find savings is sort of the $1 million question, or the, at this point, $1 trillion question, I guess. Yeah.
Do you have any data regarding provider satisfaction with Medicaid managed care products?
There is a provider, and I apologize that I didn't include that in this. There's a number of measures on the MQIS system that look at provider satisfaction with this as well. So I apologize that those aren't part of this, but they do exist and they are on the MQIS site. Okay, big stuff. So the last claims-based, ETG-based report that I wanted to show, and bear with me while I explain what these three columns are, because they are slightly different than one another. So these are the top 10 ETGs. This is just the MCO population for the most recent year, so we wanted to drill down a little bit into just one population for the purpose of this conversation. So this is just the MCO data and this is just in fiscal 15. In the rank order column, which is the first numerical column, the PM condition cost for the total population, says what are the top conditions if you spread the costs for that condition across the whole population. So the costs for depression, the per member per month cost for depression across the entire MCO population is $16 per member per month, and they're ordered from there. The next column is the costs for that condition. Okay, so $180 per member per month for people who have depression. So people who have depression in the MCO population are averaging $180 per member per month cost for depression. The next column is all costs for those members across everything that they receive care for. So members with depression, their overall per member per month cost is $559 per member per month across all their care. So the purpose of this slide was really to start to think a little bit about if we manage the populations with certain conditions, what is the potential impact for the cost for that condition, but what is also the potential impact for those members across all the types of care they receive. Again, medical only. So, interestingly, how different these can be. Some of them with a lot of impact differential, and some of them not as much. Any questions about that? Okay. Hi.
Any, like 4-quadrant value, and maybe it's coming up, where you're putting cost with outcome? Because just looking at the cost itself doesn't tell me if that's good, bad, or indifferent.
Yeah. No. I wish. So, one of the challenges we have on a data side is tying each of these, purposefully this is a de-identified data set, so we wouldn't be able to see how people with these financial experiences tie to other non-claims based experiences. So that's one of the issues that we run into. We could look at other potential, we have looked and we have done some analysis of other quality type metrics that you can look at for these populations that are claims based. So, follow-up rates and those sorts of things. That's not part of this, but a lot of the quality measures that people talk about as far as sort of long-term maintenance of satisfaction or life outcomes about, whether or not this improved their ability to stay employed and those sorts of things you can't really tie together.
Do we have then any, since we have no idea if that's high, low, or, indifferent, is there any benchmarking that you can provide us with comparison to other states or other regions?
I'm trying to think of where we would be able to get similar analyses. I mean, other states have done not exactly the same analyses. Maine has some reporting that they've done. Colorado has, Utah has. So we have a little bit of that, not exactly at this level. I think most of what we've done from a comparative look is at multiple populations to each other. So whether that's commercial to Medicaid or Medicaid to Medicare, as far as do the scales look the same? Yeah.
A really interesting feature of behavioral health cost data is that it's so driven by presentation in the acute care system that it is in fact a proxy for the quality of continuity of care. So as much in these kinds of episodes, as much as a third of the cost over, say, 90 days, even 120 days, is driven by readmission, as well as length of stay. So the differential between depression and psychotic disorders is largely driven by the length of stay. And you add to that multiple readmissions, and your episodic costs start to get high. So you can explain a little bit of the quality story in the observation of episodic costs.
And I'm
We
just gonna-
drive out readmissions.
I'm going to remind everybody to identify themselves.
Oh, I'm sorry.
Okay.
I'm Stephanie Grant. I'm from Massachusetts Medicaid. I'm the director of the Office of Behavioral Health, which is why I'm fascinated. I didn't know I was coming this morning to hear our presentation on behavioral health spend, but that's a lot of the story.
Yeah, Doris. Doris Loft with the department. Joe's made a couple references to MQIS, which is our publicly facing website on Medicaid data, and we routinely, to speak to Dr. Kraft's question, we routinely provide two comparators as well as a historic trend line of the data. So with respect to the data that's there with the utilization data and with a lot of the clinical quality metrics, you'll get a comparator to New England Medicaid programs, which is an important regional comparator since New England tends to have some very good quality metrics. And you'll also get a comparator to national managed Medicaid numbers to give you some kind of context. Where we have the old fee-for-service data, we'll have that there. And then, as I said, we've got somewhere between 3 and 5 data points typically running on average. So you do get some sense of context. It's not married to the financial data, though.
Thank you. Yeah.
Do we know the comorbid conditions of in the final, the column furthest to the right, about what's driving the costs other than a single psychotic disorder or?
We don't know it. We could find it out. The data the data would support finding that question out. We have not explored the question, but thank you. Kelly?
Joe, this spend is inclusive of inpatient and outpatient.
Yep. Yeah, this is across the board. Laboratory, all of those.
But not that.
But not France. Yes.
Question from our online group.
Okay.
Joe said this was medical only, but does it also include behavioral health codes?
Yes. Yes. The only thing that it doesn't include are things that wouldn't be paid for by the NCOs, including pharmacy. So if it's a waivered service, not in here. If it's another skill nursing, those sorts of things. Yeah.
You said that it's de-identified. Is it de-identified completely so we can only look at New Hampshire as a whole, or can we look at it by zip code?
We can do some regional analysis on this as well, and there are the analyses that are online. Again, I sort of felt like I could do this for 6 days, or I had to do it in 40 minutes, right? And that's the danger with me. I could actually do that for 6 days if you let me. My poor husband has to look at this stuff at night. It's bad. But the online tool does have this, does have some analysis by public health region, which to the conversation we were having earlier could roll up into the IDNs too if you combine public health regions. Not everything is available by region, but I think if if we learn that there's a real need for some other geographical analysis, we can talk about that.
And I guess my question is there variation across the regions, and are there some hot spotters and some bright spotters we could learn from?
My guess is we definitely see some variation in costs by the regions. We haven't done. Oh, geez, I got 5 minutes. We haven't done that sort of robust hotspot kind of analysis on individual condition levels, but when you look across the board at the regions, you see some variation for sure. Okay, I'm going to try to very quickly go through the last parts of my slides, which will probably mean that I'm going to tell you what's in them but not talk about them, and then you can find me later. So the next set of slides hones in a little bit using largely the MQIS data system, again, pulling metrics that were related into different areas, and looks at the utilization characteristics that are within both the eligibility group as well as some age breakdowns for a couple of key metrics. Primary care utilization, ED utilization, and then a really interesting metric that the department has made available on MQIS around ED visits that are potentially treatable in primary care. So there's a whole host of types of visits that are in the ED that have been designated as potentially treatable in primary care. And essentially, if you look again by eligibility category, there's a lot more utilization in some of the, what one would probably call high need populations from an eligibility category standpoint, largely in those adults. On the kid side, relative to the adults, the utilization is relatively low, both on the primary care side and on the ED side. But interestingly, the rate of potentially treatable in primary care ED visits is much closer to the overall ED visit in the kids than it is in some of the other high-need populations. Okay. Yep. So same analysis, metrics, same set of metrics, this time by age. Less than 12 months, a lot of visits, not surprising in the primary care setting for the newborns. Tapers off in the kids as the kids get older. Pretty high utilization on the primary care side, and the older adult populations on Medicaid. Similar on the ED side, and relatively a much lower rate of potentially treatable in primary care ED visits on those older adult populations. Okay, just again, quickly, a couple of key measures that, again, I pulled from MQIS. So for the period of time that the New Hampshire Health Protection Program population was covered by the MCOs prior to the actual acquisition of plans on the exchange, the MCOs did some reporting to MQIS on the Health Protection Program population specifically. So just again, for some relative information, wanted to include a few metrics of utilization across the Health Protection Program population. So, okay. So I lied. Next two slides. Because we didn't have pharmacy data linked in, I did want to include something around pharmacy. So what is, poor Molly, stop talking, Joe. What is included in the pharmacy utilization is drawn from the health plans directly, either in their annual reports or some supplemental information that they provided that talks about both the top 10 most utilized generic drugs and top 10 most utilized brand drugs. I will admit I had to look these up because I didn't know what they all were. Essentially, a lot of behavioral health related medication for depression, seizures, ADD, anticonvulsants on the generic side, and on the brand name side, really dominated by asthma medications. Again, lots of kids. And a very similar pattern for WellSense on the antidepressants, convulsants in those. And amoxicillin's way up there. So again, our ear infections continue to show up all over the place. Okay, so just, behavioral health in the MCM population. So there are a couple of key issues that we wanted to draw some very specific slides for. Behavioral health, clearly, as we've talked about before, a real need in the Medicaid population. We've seen that. These are rates of follow-up hospitalization for mental illness at 30 days, usage of a substance use specific service, antidepressant medication management, and usage of one or more opiate treatment services by the percent of the population in the MCM population. Interesting, the other sort of big ticket item in Medicaid is pregnancy. A lot of women become eligible for Medicaid because they are pregnant, and so pregnancy outcomes are very important to Medicaid. And just recently, New Hampshire became a state that was participating in the CDC-run Pregnancy Risk Assessment Monitoring System, or PRAMS, and that provides a lot more information about pregnancy-related outcomes with, and it has a designation specific to Medicaid populations. So this is 2013 data from PRAMS, and what you can see within it is that there is a trend for worse outcomes from a birth weight perspective in the Medicaid population. It's not statistically significant, but there is a trend towards that. And similarly, there's a metric known as the Kotelchuk Index that measures the adequacy of prenatal care. And similarly, in the Medicaid population, although the differences were not significant, there is a trend to sort of worse adequacy of prenatal care in the Medicaid population. Another big ticket item that we hear a lot about given the opioid crisis that we're in the midst of, which is neonatal abstinence syndrome, so babies that are also born addicted. And there was some analysis done, again, by the Division of Public Health Services. The link is there. These are relatively old data, very old data. They're working on new ones, I'm told. But just wanted to share a little bit of the data that is available around the trend in neonatal abstinence syndrome. This particular analysis did break it out by Medicaid and non-Medicaid payers, so you can see where the trends are for both of those populations. And then quickly, very quickly, before Molly literally shuts the mic off, just wanted to share some of the numbers, again, that the MCOs have reported in their own annual reports about the numbers of beneficiaries who are in complex case management. So there are some very complicated members in the Medicaid population. We will hear a little bit more about that from the MCOs themselves in a couple minutes. But just wanted to share a little bit about the experience. So what we've included in here are some of the analyses that the MCOs have done on their own populations for who is the numbers of individuals who are enrolled in complex care management. So, there's a lot of data in these slides, as you know, and I would hope that you answered a few questions. We probably generated more. But in essence, you know, what we've talked about, Medicaid is primarily kids. From a volume standpoint, you see a lot of that. Their overall health is rated pretty well for the adults on Medicaid. The self-rated health was not very good, and you can see in their utilization patterns and some of the conditions that they're contending with why that might be. And there is a lot of utilization along a lot of different areas. But at the end of the day, you know, it's interesting to note that overall, when you look at how folks feel about their interaction with the healthcare system on the Medicaid side, both on the kids and the adults, they're pretty satisfied with how their interactions are going. That doesn't mean that there aren't pockets of real issue, but across the board, that's sort of what we see.